Good evening and welcome. My name is Jeremy Welch. I'm a GP in Tewkesbury. I'm very pleased to introduce and welcome Dr. Henry Steer, who is a respiratory consultant and lung cancer specialist.
Good evening.
We're here tonight from TWNS. It's an acronym: Tewkesbury, West Cheltenham, Newent and Staunton GP practices or primary care network. And we wanted to talk about lung cancer. It is clearly not a nice subject to talk about, but it's a very relevant subject that we want to raise awareness about, and we want to talk about what's changing in the world of lung cancer and what we do to help patients who are worried about lung cancer. It is sadly a very common cancer. It affects nearly 50,000 people in the UK every single year, making it the third most serious cancer that we see. It affects mainly patients over the age of 75, or it's found in patients mainly over the age of 75. It mainly affects smokers, but it affects people from all walks of life. And I'm just going to pull out some celebrities and people we know of: Nat King Cole and Ronnie Wood and George Harrison from music, Steve McQueen and John Wayne from films. From sports, Jesse Owens, the sprinter who actually was a smoker. Johan Cruyff from football. Not only smokers, Donna Summer from music, and some of you who follow the cricket may know of Ruth Strauss, the late wife of Andrew Strauss, the ex-England captain, who was a non-smoker, and is the Red for Ruth days at the Lord's Test for cricket. So it affects a lot of people, and this is why we want to raise awareness. We want to talk about it and make it a conversation. This evening, we're going to cover a lot of stuff. We are going to cover what is lung cancer. We're going to cover what are the symptoms of lung cancer. What are the risks? What makes me more likely or less likely to get lung cancer? What do you do if you're concerned, if you've got some of the symptoms or concerns that we're going to talk about this evening? If you see your GP, as myself as a GP in Tewkesbury, what would we do? What can you expect us to do? If I'm worried as your GP and I'm doing some tests and I'm referring on to a specialist such as Dr. Steer, what will the hospital do? What's that world you're walking into? What tests might they do to you? We're going to talk about screening as well. This is quite a new thing for the UK and very new for Tewkesbury, where I'm based at the moment. We're going to talk about, if you are one of those people who is diagnosed with lung cancer, what can we do? What can Dr. Steer, what can the surgeons, what can the teams in the hospital do? We're going to talk about the different approaches to treatment. We're going to talk about the support that exists in the community and the hospital. You have the opportunity throughout this talk to pose questions online. We will try and get through as many questions as we can. Hopefully we'll answer a lot of the questions as we run through. And we will hope to be done and dusted within the sort of next 45 minutes. So we won't keep you too long, but it is a really important area that we really want to talk to you about. So at this point, I'm going to start grilling Dr. Steer, and that's why he's here. We want to pick his brain as a specialist. And so, do you know what? I'm going to start off with the very big question. Well, firstly, thank you again. What is lung cancer?
Well, I guess to start that, we should probably talk about what is a cancer.
Yes.
Essentially, a cancer arises when a cell in the body starts growing and dividing and replicating uncontrollably. And within various parts of the body, we've got cells that are growing and replicating and then dying and being replaced in a cycle constantly. And that's how parts of the body do their job. But if the machinery within one of those cells, the biological machinery, goes haywire, then sometimes those cells can start growing and replicating and dividing without stopping. And if that happens, then they form into a little lump, and then the lump grows as a tumor, as a cancer. And then at some point, that will start causing symptoms and making people poorly. So lung cancer is essentially that process that's happened in some of the cells in the lung, usually in either arising from some of the glands in the lung or some of the cells that line the air pipes in the lung.
We've got some lung pictures behind us. And now, Skin cancers. I can see skin cancers. You can see
Yeah.
skin cancers. We can all see skin cancers. Unfortunately, our lungs are inside us and we can't see our lungs. And
Yeah.
so then we have to ask the question, how do we know? What are the symptoms? What are the things that everyone should be worried about?
So yeah, and for the reasons you say, in the early stages, unfortunately, lung cancer often doesn't have symptoms until it reaches a size that it starts causing symptoms. But in particular, so the main symptoms of lung cancer are a cough, so a persistent cough that's lasting more than a few weeks. Sometimes people are breathless. Sometimes, depending on where it is, people get pains that are persisting and not explained. In particular, if someone coughs up blood, that makes us a bit more worried that there could be something more serious going on. So that's something we really want to know about and look into. If someone's getting recurrent chest infections, then that's another symptom, sign that there could be something more to this. And then there are more sort of general symptoms like feeling particularly fatigued, losing weight, having a poor appetite, that sort of thing.
And look, we've just come out of winter. You're a respiratory specialist. I'm a GP. I see a lot of people coughing, and you see a lot of people coughing. And it's really difficult, isn't it? So sometimes difficult for us, and so it's very difficult for public and for patients. And so a lot of it is really, we were chatting before we came on, we're talking about, you've got to put it into context, haven't you?
You have.
And so look, if I've had a stinking flu, well, then I expect to be coughing for a good 3, 4, 5, 6 weeks afterwards.
Yeah, and I think you've hit the nail on the head as to why lung cancer is often difficult to diagnose in early stages, because a lot of those symptoms overlap with other chronic chest conditions and are often mistaken for those other conditions. So I think the key point is that if those symptoms are unexplained, so as you said, if you've had a clear chest infection, you'd expect to cough for 3, 4 weeks afterwards. But if they're unexplained, if you've got multiple symptoms, so we know that increases the risk. If someone's got a cough and is losing weight, then that makes us more worried. And also we need to look at someone's underlying risk. So as you said, the main risk factors for lung cancer is age. So if you get older, it gets more likely, and people who have smoked for significant periods in the past. So, you know, we would not be particularly worried about a lung cancer in someone in their 20s who's never smoked, but we might be more worried about it if someone was in their 70s and would smoked a lot. So all of those things we need to sort of bring together and just sort of work out how worried we are. But ultimately, if there is still a concern, then we need to do some tests.
Yeah. So often, probably they're seeing me or my colleagues first with their persistent cough, and so I will ask lots of questions. And I apologize, I will ask lots of questions before I've even got my stethoscope out. I'm putting you in context in whether you smoked, how unwell you've been, whether you lost any weight, are you getting short of breath when you're walking up the stairs, have you brought up any blood, any flecks of blood or globs of blood in your sputum? And then we'll start examining once we've had a good sort of questionnaire going through. And then really, if I'm concerned, if you're coming to me with that sort of persistent cough, you have smoked in the past, you're not a smoker now, but you have smoked in the past for a reasonable amount of time, you used to smoke, then I'm starting to get a little bit more concerned and thinking, well, okay, I need to look into it a little bit more. I can listen to your lungs. Now, I'll be honest, I'm not going to hear a lung cancer when I'm listening to your lungs. I'm quite reassured sometimes when I hear crackles and noisy and bubbly things around that you've got more infection. But to have a look inside your lungs and a look at what's going on, I'm going to start with a chest x-ray. And I'm going to refer you through to one of our hospitals, either Cheltenham or Gloucester Hospital or our community hospitals, for a chest x-ray. I think it's worth just taking a minute to explain, when I and my colleagues request an x-ray, what we'll do is we request it on our computer system. We then ask you as a patient to ring the booking office, and we give you the number for the booking office. When you ring through, you'll open up to all of the x-ray departments across Gloucestershire. And so there is a little bit of choosing for you of what's available when, and there may be a different wait for Tewkesbury, literally over my shoulder. to Gloucester, to Cheltenham, to North Cotswolds, to Stroud, to Cirencester. But they will all be the same X-ray. Once you've had your X-ray, it then whizzes off to the radiology consultant at the hospital, who has a look at it. And we were talking about this as well. And so the radiology consultant will look at it and look, this is what they do. They're experts at looking at these images, and they will look and see if there are any previous images you've had, and they will then write a report back to me as a GP. But if they are concerned by what they see, or they're just not sure what they're quite seeing, they will automatically, I'll leave this bit to you. This is happening.
Yeah. So what, I mean, the first thing is the chest X-ray is quite a crude picture of the lungs. So it gives us basic two-dimensional picture of the lungs, and often that's good enough. But so if an abnormality is seen on a chest X-ray, it doesn't necessarily mean that it's something serious.
Yeah.
But what it means is we need to get some more detailed pictures of the lungs. So a chest X-ray is, if you like, the first screening test. But quite often we need to get a CT scan before we can really know what's going on. So what happens is, if the radiologist spots something that they think needs a CT scan, we will just arrange that scan just for the sake of speed and just getting things done quickly. So the radiologist will then do a report, and that report will trigger a CT scan, and we get pinged an email about it, so we know what's going on, and then the hospital will contact you and we'll arrange for you to come up and get a CT scan done. And what we now have is a system whereby we will do those CT scans at the Community Diagnostic Centre, which is at Gloucester Docks. And we've set up a system so we will do that as a one-stop clinic. So you come up and get your CT scan, and then late morning, the radiologist will report that scan over at lunchtime, and then we run a clinic in the afternoon. So we'll be able to get the CT scan and then see you afterwards to talk to you about it.
So it's really quite slick, and often I'm getting an X-ray report as the GP who's requested it, and I'm ringing my patient up and saying, I think we need a little bit more imaging. I'm not saying it's bad, but we just need to know a little bit more. And they tell me, oh, I've already had a phone call and I've got an appointment tomorrow morning and I've got a CT scan. I said, fantastic. So it's good that the system is working, it's all going through. I will still keep ringing my patients just to make sure, but it seems like it's completely working well.
Yeah, the other thing, so that probably about half of the people who come see us in our cancer clinic come through that route from the chest X-ray.
Okay.
But if your GP, if your GP is worried about cancer, or that cancer needs excluding, because the chest X-ray will pick up about 80% of lung cancers, but it does miss some. So if your doctor is still worried, or for example, if you're coughing up blood and you've got a more worrying symptom, they might just send a referral straight to us, with or without a chest X-ray, in which case what we will do is we will then arrange the chest X-ray, the CT scan from our end, and see you in clinic. The other quite common thing is when people have CT scans for other reasons, and it picks up an incidental lump in the lung. So we have quite a few referrals that we see in clinic who've had a CT scan of their kidneys or their shoulder or something, and it's picked up something in the lung that needs looking into. So there's different routes, but essentially, whichever way you get referred to us, we will get you up to our clinic and try and get everything done that we can in one stop.
So so Dr. Steer is very right to pick up on that. If you see me and one of my colleagues, and you've actually got quite a lot of the symptoms we've talked about, you've lost some weight, you have been a heavy smoker, you may have coughed up a little bit of blood in your sputum, I would often use what we would term a 2-week wait rule, which is the urgent pathway through to Dr. Steer and his colleagues at the hospital, to expedite your next level and more invasive and diagnostic testing for you. Which then leads on to, okay, so you've got to see you at the hospital, and you may have had your CT scan. You generally would have had your CT scan before.
Yep.
If you're seeing something that you're not happy with on the CT scan, the radiology consultant is not happy, what happens to my patient next? And
Yeah, so a CT scan, a chest X-ray CT scan, they are just pictures. So they will tell us there's something there. Sometimes we can get a good idea whether it's cancerous or not, but they can't tell us for definite what it is usually. If we see you in clinic and there's something on your scan that we're worried might be a lung cancer, there's a few different things we need to know. So we obviously need to know what it is. And the way of knowing what something is essentially to either get a biopsy of it or have it removed. Either way, you can then send a sample of it off to the lab, and they can look at it under the microscope and they can say, yes, this is a cancer and what type of cancer it is. So we will need to do a biopsy at some point if we can. But we also need to know where it is, i.e., if it's a cancer, is it just in that part of the lung or could it have spread somewhere else? So we need to do some scans that do what we call staging. So tell us what the stage of this lump might be if it turns out to be a cancer. And so we often, or we might need to do another special sort of scan, which is called a PET scan, which is essentially a bit like a CT scan. It's done over in the Cobalt Centre in Cheltenham, but we inject glucose into the bloodstream before the scan, and so bits of the body that use glucose, i.e. are active, shine up as bright on the scan. So it helps to tell us whether something is active, i.e. the tumour is often bright, rather than just a bit of scarring, which is often not using glucose, but also it scans the whole body. So it tells us whether there's anything anywhere else in the body that we need to be looking at. And we often need to do, we might need to do a brain scan as well, just to complete that staging. So
a PET scan is an infusion or
it's
injection?
an injection of glucose, and then you run through the scanner. So it's like a CT scan.
Okay.
Yeah. We also might need to know some more information about your fitness, for example.
Yep.
And in particular, do some breathing tests to know sort of how well the lungs are working, how strong the lungs are, because some types of lung cancer treatments, such as surgery or radiotherapy, we need to know that people are going to be fit enough to have those.
Yeah.
Or, for example, if someone's got a history of heart disease, for example, we might need to look into that. And we also will talk to you about, what you want to do, and sometimes with these sorts of things, there's different ways of playing something. So we'll talk to you about what's important to you and what your wishes are. So what we will try and do is get all of those tests that we need to do. We will try and book all the tests that we think you might need in one go, such that you go off, you have all the tests that you need, and then once we've got all those results back, we will discuss all those results in a meeting we have each week, which is called a multidisciplinary meeting, where we all sit around in a room, and there's myself and my colleagues and our radiology specialists and our pathologists and our cancer specialists and our surgeons, and we go through all the cases and review all the results and try and work out what the problem is and what we need to do about it. So after that, once we've got those results back, we will then obviously contact you and see you and talk to you about
So it's quite a busy appointment. There's a lot of different angles.
Exactly. It really is. There's a lot going on, but we'll try and explain to you what we're doing and why we're doing it. But we will try and, it's a bit of a maelstrom. So there may be lots of tests being done, bang, bang. And then when we've got all the information we need, we will see you. Now, the key person, the really important people during this whole process is our lung cancer nurses. And so at your first appointment, if this is looking like it might be a lung cancer, you will meet our lung cancer specialist nurses, who are very extremely experienced nurses who nursed patients with cancer for years, and they will give you their contact details. Basically, that number is your contact throughout this entire journey, and they will stay with you throughout your journey. Even if this doesn't turn out to be cancer, then great. But if it did, then they will stay with you and be a point of contact throughout any treatment and then after treatment.
And and so many patients come back to us in general practice world and talk about, I said, who did you see? I don't know, but Debbie was so nice, and I couldn't remember what was said, and so I rung Debbie, and
yeah,
they're
amazing. They are absolutely amazing, and you know, they actually have a lot more contact with patients than we do, because they will, throughout this journey, they will be phoning people and supporting them. Yeah.
Okay, so you've done all your tests you talked about, and your specialist nurse has helped me through those tests, and I forgot what I was doing, and so I rang them, and they put me straight and reassured, and then things have come back, and you've discussed in the MDT meeting, and I think you now to talk about the thorny issue of in that small percentage of patients, and it is not everyone who sees Dr. Steer has lung cancer. A very small percentage will, but some unfortunately will. And then really wanted to sort of tackle about different types of lung cancer, different stages of lung cancer, and how we kind of tackle them.
Yes. So in broad terms,
that was a big question, I know.
Yeah. So as I said, so there's different types of lung cancer and there are different stages. So the two main types, the most common type of lung cancer is one called non-small cell lung cancer, and unsurprisingly, the other type is small cell lung cancer. Small cell lung cancer makes up about 1 in 6 lung cancers, maybe a bit less, and that is a cancer that is usually managed with chemotherapy type drugs.
Okay.
Because quite often it has spread at the time of diagnosis. Non-small cell lung cancer is a cancer that, if it's an early stage, we like to try and treat with surgery to remove it.
Okay.
And so the way we stage cancers is there's a system that we call stage 1 to 4, but essentially stage 1 is a small cancer that's within one part of the lung.
Okay.
Stage 2 is either a larger cancer or a cancer that's just spread to the glands, but in that same part of the lung, so that can all be removed surgically.
Okay.
If it's stage 3, then it's spread to the glands in the middle of the chest.
Okay.
Sometimes that can be removed surgically, but if we did that, we would probably need to combine it with chemotherapy type treatments.
Okay.
Then stage 4 is where it's spread outside the chest. So it's really important to know what stage it is, because the treatment options are really different.
Okay.
And as I said, with early stage lung cancers, we can treat with the aim of curing them, either through surgery or a mixture of surgery and chemotherapy, or with high dose radiotherapy. So all of that high dose radiotherapy is also able to cure cancers for people who are not fit enough or can't have surgery.
If I was to be at stage 1 or stage 2 and I need surgery, where would my surgery be?
So in Gloucestershire, we refer north of the county up to Birmingham.
Okay. Yep.
And south of the county down to Bristol. So Tewkesbury would go up to Birmingham.
Okay.
And essentially around the country, there's a number of surgical specialist centres. So we don't have thoracic lung surgery in Gloucestershire, but our surgeons come and do clinics here.
Yes.
And then they would, so you would either be seen in Cheltenham at the surgical clinic, or sometimes you might have to go down to Bristol to be seen, and then the surgery would be done. Yeah.
So I've had surgery, and then can we just talk a little bit about chemotherapy? Can you sort of disentangle it a bit, or?
Yes. Yeah. So there's in the past, so 15, 20 years ago, we just had chemotherapy for lung cancer, but in the last 20 years, and especially in the last 10 years, there's a lot more options.
Mm-hmm.
And so the different drugs we use, we do still have chemotherapy, but these days we usually combine that with a type of drug called immunotherapy, which is based on medications that stimulate the immune system to attack cancers. And the other thing we do is whenever we get a biopsy which shows a lung cancer, we send it off down to Bristol, which is our regional or genetic laboratory, and each person's lung cancer will have its genetics sequenced individually.
Okay.
So what happens is once we've got the biopsy back, that biopsy gets sent down to Bristol, and they will do genetic sequencing on it, and that will tell us which particular drug that person's individual cancer will respond best to. And therefore the oncologist can then tailor the drug precisely to what drug that particular tumor is most susceptible to.
It is huge. I mean, 20 years ago, I was working in oncology, and a lot of the stuff we use is nowhere near being used. It's moved on miles.
It's yeah, and even since I've been in Gloucester since 2013, the landscape has changed massively, and the outcomes have changed massively. So yeah, there's a lot more options now, and the the responses we're seeing. So not in everyone, but in some people are remarkable, really.
We skipped past a little bit. Sorry, my fault. So sometimes you're going recommending straight for surgery, but sometimes you're needing to get some cells by another route.
Well, we would. So going back to what we said about what we need to know. So in terms of we need to know what it is. So we would usually, if we could, try and get a biopsy.
Yeah. A,
to confirm it's cancer, and B, to determine what type of cancer it is, and C, to get those genetic tests that we spoke about. So the two most common ways we do that in lung cancer is with a camera test, which goes down into the lungs, and we call that a bronchoscopy, and often it's a special type of bronchoscopy with an U-bus, which is essentially got a little ultrasound probe on the end. And that's a procedure we do under sedation with throat spray. So anyone who's having a bronchoscopy would come up to Gloucester for a morning, and we would do that with spray to numb the throat and then sedation to make people drowsy. It's not a general anaesthetic, but often people are really drowsy and don't remember too much about it. So that's the camera test. The other way we can often get biopsies is what we call a CT guided biopsy, which is where you come up for a CT scan, and then the radiologist with you in the scanner, the CT scanner uses the CT scan to guide a needle very accurately with local anaesthetic to freeze the skin, to guide a needle into the lump and to get some.
And that wouldn't be the original CT. They would
do another CT on the table. Yeah, and it's done within the scanner. So you put the needle in, you do a scan, check the needle exactly where it needs to be, and then take the biopsy.
And presumably that's dependent on where in the lungs and how
exactly. Yeah. So we can get a camera down to things that are in the middle of the lungs to sample the glands in the chest, but we can't get a camera out to the edge of the lung. So if there's something at the edge of the lung, it would need to be a CT.
And that would all be discussed in the appointment.
Yeah, we'd have a good idea on from the CT scan what in that first appointment what we would be doing.
So staging wise, obviously the lower number, 1s and 2s, better. 3s and 4s, still definitely things that can be done. Definitely. But obviously better that we pick up lung cancer early, and this is a big part of why we're talking, and we want to talk to you because we want to talk about seeking support if you've got persistent cough, if you've got the blood, if you're feeling tight, if you're getting more short of breath, those things that I might get better. Absolutely, this is what we want you to come and contact us at the general practice for, and we're very happy to talk through, examine, review, maybe review again in a few weeks' time, see how things are going. But the new thing that I wanted to talk about was about lung cancer screening. So this is something which absolutely, when I was at medical school, did not exist. Actually, a couple of years ago, didn't exist.
No, and it started. Well, there were a few pilots in the UK which started 5 or 6 years ago, and then the evidence from a big European trial came out showing that this was doing screening could prevent people dying from lung cancer. So in about 2022, it was recommended as a national screening program. It's a huge amount of work. So all those CT scans. So it's being rolled out gradually with the aim to have full coverage by 2030.
Okay.
So in Gloucestershire, we are part of a network that goes down to Bristol, Somerset, and Wiltshire. So we've been sort of screening within that network, and the CT scanners have been going out on trucks. So we started in Gloucester over a year ago, and we're sort of moving around the different localities. But yeah, the aim of screening is to find cancers in that really early stage, often, usually before they've even caused symptoms, at which time they're far more likely to be small stage 1 or stage 2 cancers that we can remove and get rid of. And the evidence is that is true. So 75% of the cancers you find are stage 1 and 2.
Brilliant. So we're getting our head around this in general practice. So for patients in our region, Tewkesbury, West Cheltenham, Guildford, and Staunton, apologies, I hoped to get out to you guys and talk before this went live, but I think quite a lot of you have already been contacted from the lung screening team. And so they are targeting 55 to 74-year-olds.
Yep.
They are looking at medical records for risk factors, for family history, for smoking. They are contacting you as patients, and we did get a few calls from patients. They weren't sure if it was okay because they were being contacted out of the blue, it felt, and asked some questions. It's delivered by a team locally called In Health, and they will contact you and they will ask a series of questions, and some patients will reach a threshold that they will say, we need to do a CT scan. So not everybody in 55 to 74 will get a CT scan.
No. So yes, they will do a risk assessment, and that's based on a series of questions. And there's been lots of studies validating, how good those questions are at assessing someone's risk. They don't assess whether they've got cancer or not. They just assess their risk. And if someone is in a higher risk group, then they will go on to get a CT scan. And then they will then get an appointment at the scanner.
Yep.
Which is for here.
Tesco's at St Albans.
Yeah, down in St Albans in Gloucester, and come up. And at that appointment, they will then meet a nurse and who will just run through some questions and talk to them about the scan, and then go ahead and get the scan. And
it's a straight scan. There's no injections with this
no
scan.
injections, non-contrast. Takes like a few minutes, and then good to go. And then that scan gets electronically whizzed around the country where radiology specialists are reporting them. And then if there's an abnormality on it, then it gets flagged to us, and we will look at all those scans in a meeting. And often, most of the time, the abnormalities that we find are just things that just need following up. So often we find tiny little nodules that are sort of low risk for being cancer but need to be monitored. So we might then do another scan in 3 months and then another scan in a year. But if there is something that looks like it needs investigating now, then you'll be referred up to us at the hospital, and then we will see you in our clinic.
It is it's a brilliant project, and it feels like the right thing to do. And often when these things happen, we think, well, why weren't we doing this before? I'm not blaming you for that.
No, well, we just didn't have the evidence for screening, because you need to know that what you're doing is actually going to achieve positive outcomes, i.e., are you going to save lives?
Yeah.
So that the big studies were only sort of, the results of those only came through in 2018, 2019.
Okay.
And then there was, as I said, the logistics of rolling it out are immense. So, and to be fair, the government and NHS England have backed it and have put money into it. But it's from when it started in 2022, it's going to take 8 years to actually get up to full coverage of the whole.
Okay. And is it going to, the answer, is it going to be a recurring process, or
So people will come into that at the age of 55. they will get invited for screening.
Yep.
Obviously, at the moment, we're still trying to get through all the people aged 55 to 74, which is why there's a huge amount of work to get through. But then if your CT scan is completely normal, you'll get another one in 2 years.
It's 2 years.
Because there's good evidence that actually if your scan is normal, the risk of having a problem in those 2 years is low.
Okay.
Yeah. So it's then every 2 years until the age of 75.
It is a slightly different screening. So a lot of screening that we're all aware of. So for ladies for breast screening or for smears is a very specific screening looking at one area of the breast tissue or at the human papillomavirus for smears these days. Actual lung CT is picking up some other things in your chest as well, isn't it?
It is, yeah. So we're picking up a lot of we're obviously looking at the lungs, but when you scan the lungs, you can't avoid scanning the heart and often the top of the kidney. So if we see a major problem there, then we will flag that. And so we will let you know if there's something important that needs an incidental finding that needs looking at.
So that process, those reports are coming back to us as GPs, and then we're not all of them actually. Some are coming back to us.
It depends what it is. If it's a finding. For example, we sometimes see that people have little crush fractures in the vertebrae, but that can often be an old thing that's not causing any problems or symptoms. So in that situation, you'll just get a letter from the screening team saying, we found this problem. If you've got symptoms, book an appointment to your GP. If it's something more significant, then we might refer to the GP and ask them to make an appointment. Or if it's something potentially serious, for example, a heart problem, then we might refer directly to the cardiologist. So we will sort of manage whatever it is, just dependent on what.
Yes, so be reassured whether it's found, somebody will be in contact regarding, but so we are just finding our way with this a little bit because it is new, exciting, but it is new. But there will be some patients who get a different response than they expected because obviously we're primarily looking at the lungs. So if you have heard from this team, please take up the offer, go through with the questions. If you are not deemed high risk, and that's a good thing, and so not having a scan is a good thing. If you do need a scan, that's equally a good thing as well, because you are deemed at risk. We need to have a look a little bit more.
The only thing I would say, so if you're not high risk, and as you say, and you don't need a scan, then that is a good thing. But if you were subsequently to develop those symptoms that we were talking about, not having a scan just means you are in a low risk group. It's not a zero risk group. So if you were to develop those symptoms that were concerning, then you should still go and see your GP and get investigated. Yeah.
So we have covered a lot of things tonight. So we've talked about what our lungs are and what lung cancers are. We've talked about the sort of signs and symptoms that you might prick your ears or worry you about the cough, the shortness of breath, the blood in your phlegm. We've talked about a little bit about risk factors. We are going to pick up a bit more about risk factors for lung cancer. We've talked about what you do if you're concerned, what I might do or my colleagues in general practice, what tests we might do, what tests may happen with the specialist, with Dr. Steer and his colleagues in the hospital. We've talked about the new innovation of screening, and this is something that we will be seeing more of, and obviously every 2 years, as Dr. Steer has said. We've talked about if you are diagnosed with lung cancer, the outcomes of the treatments, the interventions are far superior to they were. It is still a serious cancer, and it will have an impact on your life, and it will be some quite significant treatments for you, whatever. We would like to pick up more about how we can stop ourselves getting lung cancer. One of the stats that I'm looking at around, I found that 79% of lung cancers are said to be preventable, and 72% of lung cancers are said to be related to smoking. And so the primary thing that we want to talk about is smoking, is stopping smoking, or is reducing smoking, and trying to find ways to stop smoking, because that is the risk that you see. And
exactly. That's by far the biggest modifiable risk factor. and it's never too late to stop. So as soon as you stop smoking, your lung cancer risk starts falling. And if you've stopped smoking for 10 years, it's dropped by half of what it was. And if you stop smoking and you are diagnosed with lung cancer, then stopping smoking is really important in terms of meaning that you might be able to have surgery and other treatments that you might otherwise not be fit for. So really important, stopping smoking. And that's probably the most single important thing that anyone can do to reduce their lung cancer risk.
So we've actually had a question come up, which I might pick up now. Am I more likely to get lung cancer if I have COPD, chronic obstructive pulmonary disease?
So COPD is usually caused by smoking. So the answer to that is yes, your risk is higher than it would be in the average population. COPD is actually also in itself a risk factor for lung cancer. By most people with COPD don't get lung cancer, but it is something that it's important just to be aware of. And therefore, if you are getting those symptoms that we talked about, so a persistent cough, new cough, unexplained worsening breathlessness, recurrent chest infections, infections that are not fully clearing up, that you see your GP and
or specialist nurse at the practice.
Yes, and I would say to if you are worried, if anyone's worried about cancer and you see your GP, I would encourage you just to tell them that that's what you're worried about, just so that they know what your concern is and can explore it with you.
Is there anything else we can do to lower our risk of lung cancer through life? So stopping smoking. I'm going to come back to vaping in a second. But apart from smoking, I mean, generally, I talk to patients that all cancers, unfortunately, are more common with unhealthy lifestyles. Now, smoking is not the only unhealthy lifestyle.
Yeah.
Keeping fit, keeping active, trying to keep our weight down are all positive things for any type of cancer reduction.
That's true. I mean, in terms of specific things, there's sort of so air pollution, wood smoke in the home have all been associated with lung cancer. There's certain things we can't control very well, like some environmental factors. Fortunately, not in Gloucestershire, but if you live in Cornwall, there's sort of environmental radon around and things that you can't control. But I mean, other than smoking, the most important thing are things that are sort of broadly sensible health advice for a number of different diseases, which is good sort of balanced, healthy diet and keeping yourself fit.
So stopping smoking. So it's really easy for me and you to say stop smoking because it increases your risk of lung cancer, and 72% of lung cancer are associated with smoking, but clearly not that easy to do. And so I want to highlight to people, obviously a lot of people will try and stop smoking on their own. They will pick up nicotine replacements from the chemist, or they may well contact Healthy Lifestyles Gloucestershire. So if you were to Google Healthy Lifestyles Gloucestershire, the link will be on the Facebook pages after this as well. Or to put Stop Smoking Gloucestershire, it will come up with links of how you can get in contact with a smoking cessation advisor who will be able to support you with this journey, because the evidence shows you more than 50% more likely to stop smoking in conjunction with someone else.
Yeah, absolutely. I mean, stopping smoking is super hard, and if you've been smoking for a long time, the brain is addicted to nicotine. That's just the biology of it. It's nothing, there's nothing judgmental about that. That's just the biology, and therefore stopping smoking, just going cold turkey, is really difficult. So, I mean, some people can do it, but if, as you said, if you're given support in terms of sort of nicotine replacement and there are other medications, then you are far more likely to quit. The other thing is that I think is a really important point is you may need to try more than once. So it's not uncommon for people to try to quit and fail. What you need to not do is then sort of give up. Oh, I've tried and I can't.
Yeah.
actually what needs to happen then is have a think about what was it that caused you to start smoking again, have a think about those triggers and regroup a bit. And then when you're in the mental frame to start again, have another go and just learn from what you did before in terms of your triggers, what triggered you off smoking, and try and change those things. And that may need to happen 3 or 4 times.
Yes. Yeah.
But the first thing is you've got to get your mind right about stopping. As you say, there is support from Gloucestershire Healthy Lifestyles. I guess we can put that contact number in the chat.
Go on afterwards, absolutely. Vaping. I can't not ask you about vaping while you're here. And so I see a lot more people vaping these days than smoking.
Yep.
And it's sort of a mixed bag for me as a GP. I mean, I'm glad they're not smoking.
Yeah.
It's still probably not ideal, the vaping.
No, as you say, it's a complete mixed bag. And so as I said, so vaping is a form of nicotine replacement.
Yep.
In the same way that patches and lozenges and inhalators are nicotine replacements. So for some people, they might find vaping helpful to get them off tobacco smoking. And a really important message is, although we don't think vaping is harm-free, it is way less harmful than smoking tobacco. So when you burn tobacco and inhale that into your lungs, you are inhaling thousands and thousands of toxins and what we call carcinogens, which is basically those toxins that cause mutations in cells that make them turn cancerous. So the most important thing is to get off tobacco. If you need to use vaping to do that, then I would say go for it. What you then need to do is then wean yourself off the vapes.
Yeah.
Big concern about vaping is people who get into vaping not to wean yourself off tobacco, just as a gateway, but that's a separate discussion. Now, vaping, we don't think it's harmless. We don't really have the long-term data to know exactly what the harms are on a population basis, and that data will probably take decades to come through, like it did with cigarettes. It was only in the 1950s that it was proven that it was harmful. But vapes do contain, as well as the nicotine, it's not the nicotine that is necessarily causing the problems in the lungs. They contain solvents and they contain flavorings. And when you burn those solvents and then inhale them, they do produce some of the harmful chemicals that we can see in tobacco smoke. Far fewer, but some of them. And there is some scientific studies that show that when you expose cells in a dish to those chemicals, that they start misbehaving in a similar way. So vaping is not harmless. It is far better than tobacco smoking. So if you need to do it to get off tobacco, then I would say go for it, but make sure you then wean yourself off the vapes.
We've got another question actually. It's about passive smoking. I'll pass this one to you. And does the risk decrease as you get older?
Yeah, so passive smoking is quite common. It will increase your. So what we're talking about with all of these things is risk. You can never say for 100% certain that one person's cancer was caused by this one thing, but yes, being exposed to passive cigarette smoke will be a risk factor. It will be a relatively weak risk factor compared to smoking yourself, but a bit like being exposed to some wood smoke in the home and things, it is a risk factor. But yes, the risk does decrease as you get older. So people who smoked or exposed to passive smoke when they were younger, in their 20s, etc., by that time they're in their 40s, 50s, 60s, their risk will be much lower and probably almost back down to the risk of somebody who'd never smoked, although not quite.
We've got another question about recurrent chest infections and a diagnosis of cancer being made after the recurrent chest infections.
Yeah, so recurrent chest infections, often indicate recurrent or persistent respiratory symptoms.
Yep.
So again, that is, as we said at the beginning, that is one of the symptoms that we would want to know about and would want to investigate. So if you know, on your second or third course of antibiotics for chest infections within, you know, a few months, or if you've had a chest infection that's not really fully cleared up, then that's something to talk to your doctor about. And again, go to your doctor and just say, look, do you think I need a chest X-ray?
I mean, even if you're not seeing the same doctor, your medical records will indicate, and actually it will start to prick all of our ears if you're here. Hang on, it's the second or third. Actually, we're not winning with this one. We need to look into this a little bit more.
But I mean, also there are other causes of recurrent chest infections that are not cancer,
absolutely,
that we still need to know about. So you know, there's lots of reasons there to warrant further tests.
So, is there anything else that we should be talking about? I mean, we've covered a lot tonight, and I'd say the lung cancer screening for me is a really exciting thing that's happening, and it's a huge move on because it is that internal organ. Let's see it a bit earlier and pick things up at that early stage, which is, as you very rightly say, is that they are the treatable stages. The
only other thing I would say is we are seeing more lung cancers in people who've never smoked.
Yeah.
Still very rare. So, you know, non-smokers are a very low risk of getting lung cancer, but we are seeing it coming through, and the numbers are on the increase. No one quite knows why the numbers are increasing, but it's probably related to lifestyle factors and pollution. So again, those symptoms in people who have not smoked, although we are less worried about lung cancer in that group, if those symptoms are unexplained and worrying and not going away, then we would still want to be getting a chest X-ray.
So I don't think we've got any more questions at the moment. If any more questions do come through over the next few days, I will try and respond to the questions, or if they require a specialist, I will contact Dr. Steer to just give me some advice going forward with them. But thank you so much for listening. Please do mention this to your friends and family. The videos will be able to view it again and shared around for other people to look at. And any of those symptoms persisting, if you're worried, absolutely contact the surgery. See your GP, see your specialist nurse, who will examine and potentially start some investigations. So thank you very much to Dr. Steer for his time and coming over tonight, and for all the work he's doing in the hospital and the innovation and that's helping our patients. And thank you for listening. Thanks, guys.
Good night.